Good evening, everybody. Can you all hear me okay? All right, well listen, I want to thank you for being here, coming to the Prostate Cancer Awareness event at Mount Sinai. I'm Dr. Keithan Badani, Vice Chairman of the department, and I have the distinct honor and privilege of introducing our host for tonight, Dr. Tewari. Obviously, you all know him, and I think the important point I want to make, and I don't want to take too much time because I want you all to hear what he has to say, is that there's nobody else who is as much of a staunch advocate of recognizing, managing, treatment, and eradication of prostate cancer. And so for this month, which is the Awareness Month for Prostate Cancer, you probably have seen the push-up challenge that has extended not just in the walls of Mount Sinai, but to NFL teams with the Atlanta Falcons, football clubs, ABC News anchors. This is a gentleman, Dr. Tewari, who really has a passion for trying to do better with this disease, and there's nobody else in the world that shares that passion. Nobody can match it. So tonight is the culmination of Prostate Cancer Awareness Month with this event. And obviously, it's Dr. Tewari who's going to lead this because, again, he is the biggest advocate for eradication of this disease. So with that, I'd like to introduce my friend, colleague, my boss. Dr. Tewari, come on, please.
When did I become the boss?
You know, you've been my boss since I was a medical student. So.
That's fair.
That is fair. Although we both have a boss that's here too.
Yeah. Our own mentor, Dr. Menon, is here in this room, so we always have to be, meaning me and Keithan were at the same place in Henry Ford Hospital in a certain point in my life, and that led us to have a relationship, friendship, which brought us all together, and our department has about 46 faculty, and all of them stars in their own rights. If I need my kidney surgery to be done, he's the guy who's been doing it. So, but with that background aside, why we are here today? Just because this happens to be a month where we are supposed to talk about prostate cancer? Possibly yes. But there are other stronger reasons. Something has been happening to prostate cancer field in last few years, that the mortality due to prostate cancer is going up, not going down. And it used to be in last 20 years, there was a lot of screening being done, a lot of testing being done, and the mortality was going up. But for last 5-6 years, there has something happened that prostate cancer mortality is going up. First time when we are seeing a patient with prostate cancer, they have more aggressive cancer. First time when we are seeing a patient with prostate cancer, they may have what we call metastasis, that's the cancer has gone to the lymph node or has gone to the bones. And the least what is happening is that an organ which is supposed to contain this cancer within is not able to contain the cancer within, and these cancer cells are creeping a little bit outside the capsule, right where the nerves for the erections and the nerves for urinary control are there. So basically we are finding this cancer a little bit too late, and it's our responsibility to kind of bring up that discussion right at the forefront and think about what we can do to change that. In this room, there are patients, there are men with different journeys. Some of them have already dealt with this cancer, they may be 10, 20 years away. Some of them may be dealing with some annoying PSA issues or recurrence issues. Some of them may have tried the first round of treatments for the metastatic disease or aggressive cancer, and they are wanting to know what is the new one for them. Some of them haven't had a treatment, and they need to decide what's the best way to go for them. And there are more than one options, and that's a very important question in their mind. Some people have been diagnosed and have been recommended by one of us that they have cancer, but they don't really need a treatment because their cancer is not very aggressive. Sometimes it's not easy to digest, sometimes it's not easy to understand. Cancer, and don't do anything, what will happen? Some of you may have had a biopsy done some time ago, and biopsy didn't show anything, but the PSA is still rising and you are worried about what's happening. I've already had 3 biopsies, what's going on? So that's another group of people. And there are some who have a family history of prostate cancer. They have elevated PSA, they happen to be having a brother and another person in the same family having prostate cancer, and they genuinely want to know if they have cancer. That's different groups of people, some at risk and some with the diagnosis of prostate cancer. At this time, people who have a diagnosis of prostate cancer in the United States, if they want to live in one city, everyone decides to live in one city and maybe spouses will not be allowed. They can fill in the entire city of Chicago. There are over 3 to 5 million people who have or had prostate cancer. So it's a very common cancer. In order for us to have a discussion about prostate cancer, it's important to have a discussion which is aligned to a particular group, what they need. So my desire today is to introduce the topic, get a conversation going, and possibly every month or 6 weeks, we can have sessions aligned to an active surveillance, at-risk, metastatic decision process. That kind of, and we will go into the deeper dive of each one of them. I have some slides which will highlight the numbers which we are talking about, that prostate cancer happens to be one of the commonest male cancer. It tends to be diagnosed in over 200,000-300,000 men, but we still manage to lose maybe about 35,000 men every year due to prostate cancer. Prostate cancer is an immense disease, but right in the outset I want to highlight one fact. I have seen personally in my last 20-25 years dealing with maybe over 20-30,000 men with prostate cancer, that many men owe their prostate cancer journey success not to the men, but to the women in their lives. That's a real fact. I have seen many daughters, wives, nieces calling for get it checked, get it checked, get it checked, and men, we have a little bit of an invincible approach that we are fine. We don't want to talk about it, and that's what I'm bringing at the forefront of this discussion, that we need to talk about prostate, we need to talk about PSA, we need to understand what is 4K, what is an exo, what is select, what is an OncoDX, what are the other testings there. So I will be talking about these different tests first, then I will open it up for all of you to ask questions, and I will bring the panelists and I'll introduce the panelists who are there. But I want you to just know a little bit about me, about how did I get involved with the prostate cancer journey, a little bit, few boring slides, and then I'll get on to the substance of it. So this morning at 5 a.m. I was thinking about what is prostate. So let's look at it. This is the bladder, this is the prostate, this is the rectum. Prostate happens to be just in front of the rectum, has different zones, has a muscle, there is a backbone, there is a blood vessel where there are some neurons, and these green structures are the nerves which are going through and through. And I'm drawing this morning. For you, I simplified it. It's a very compact organ which is hiding inside the male pelvis in the lower part, has an outer shell which is known as the capsule, an inner pulp which is the prostatic gland. In that gland, there are many different kinds of cells. Just outside the prostate, the prostatic capsule, are certain nerves which are literally hugging and touching the prostatic surface, and they are in transit to the penile tissue. They are in transit to supply to the urethral muscles which control the continence. They are in transit to also supply the pelvic structures including bladder, seminal vesicles. All that is packed in a very narrow space. So this is one operation which is not easy. This is not an organ easily tackled because it happens to be deeply embedded within very important structures. If it is found, when it is 100% within the prostate, it's an easy battle to fight. But if it is trying to creep on the surface, it's not easy to fight because the battle becomes microscopic, not millimeter, not centimeter discussion. And that's where a lot of challenges come, and I'll be happy to discuss about it either today or over the time. But this is that complex anatomy. This is the prostate gland which we talked about it. I also want you to understand prostate cancer is a very mixed disease. Many people get the diagnosis of prostate cancer, but not every cancer is alike. And it connects with me with a journey which I had growing up in a northern part of the India. Has anyone heard about this book, which was actually in the Reader's Digest and also National Geographic? It was published. I grew up in the north of India, and I used to hang around with my grandfather, and my grandfather used to tell me the stories. And one of the story was that just like we see in US bears here and there, and in upstate I have problems with the bears, the deers come some places. Tigers were present in Indian habitat. But they coexisted, they didn't cause too much of a trouble. And then suddenly a story evolved that certain tigers became a little bit crazy. If there were thousands of tigers, 5 or 6 of them became crazy and they started killing humans. And that became a major problem in India at that time. And my grandfather, who used to be in a job which involved him going from one village to the other village, either on a bike or walking. So he had experienced that. He told me about that story. And this is that police station where all that was happening. So that led to a whole story, a movie about man-eaters of Kumayu, or how that story evolved. So these tigers were wounded tigers who couldn't go for the normal prey, and they started going for the humans, which were an easy prey for them. But people didn't know how to deal with them, so they started randomly killing tigers. This is the time when one hunter killed maybe 7 or 8 tigers, and they got a picture. But none of those tigers was actually the man-eater. Man-eaters were too smart. They were hiding somewhere else, and the innocent tigers were being killed. Then they got an Irish hunter brought into that part of the India, and they assigned him to deal with it, and that he was a good tracker. He knew what he was doing. He finally got to the tigers, but in that bargain, he saved the other ones. And that's the reason there was a book published. His name was Jim Corbett, and he was known as a gentleman hunter. And he used his book proceedings and everything and created a sanctuary for the tigers, and it's very common. If you go to India, you must visit Jim Corbett Park because that's where the tigers live, and they are coexisting without any problem. That story was in my mind, and when I came here in 1993 and then early on, there was a lot of hue and cry about the PSA, that the PSA is over-detecting, PSA is causing too many biopsies. There were similarities between prostate cancer and the tiger story, which I knew. And I was a surgeon, so I had to kind of connect with it. Am I going to be a Jim Corbett kind of a surgeon? Or am I going to be just the other people who are taking pictures without knowing who is an aggressive tiger? So that is the journey I took, and I think there are 3 different kinds of prostate cancers. These are the Gleason 6s, and sometimes Gleason 7, 3 plus 4 with a small volume. They are there, they are scary, but they are not really going to do anything bad if we manage it right. I have couple of thousands of patients of this kind, and I at least remember 4 or 5 or 6 of them. Then I thought it was Gleason 6, and sometimes they grow. They do grow, but if we keep an eye on it, every couple of years we do an MRIs and biopsies, we can pick them up. Then there is in Gleason 7, most of the time what we call an intermediate risk prostate cancer. This is the one, but if you focus deep into it, you will see there is not even teeth in there. So they are scary, but they can be tackled, and this is the kind where we can really do a great nerve sparing, we can really do a great radiation, we can really do sometimes focal therapy. All the options become an option for this group of cancer, which is intermediate risk and has yet not gone anywhere. And then, of course, there are lethal Gleason 8s and 9s and 10s. Sometimes we treat them just with one treatment, sometimes they need other treatment. We still manage to beat most of them, but many times there are recurrences, and many times the nerve sparing cannot be as good as it can be. And this is one of the pictures from that cancer, the Gleason 10, which I lost the battle. I mean, we took it out, we gave everything, but sometimes this cancer is smarter than us. So I got into the depth of what is this cancer, and I want you to understand, this is the bladder, this is the prostate, and inside the prostate, one bad cell started becoming 2 or 3 or 4, but it's still within the gland, and we call it Gleason 6. When it breaks between this glandular architecture, it becomes a stromal cancer, we call it Gleason 7. Then it finds a blood vessel, it finds a nerve, and it tries to escape outside the capsule. That's where the problematic cancer comes. What we call that this is now extra prostatic, meaning it's trying to creep out of this, and it's now becoming a problematic cancer, and then from there it can go to the bones, it can go to the lymph nodes. And we diagnose a lot of cancers. But do you see a wolf? One of them, the rest of them, they are sheeps. And if we go with a gun to all of the sheep, poor sheep, wolf will be the first one who will hide out and run away. But this wolf exists. But me as an expert has a responsibility to unhide for you whether you have a sheep or you have a wolf. Because it takes a little bit of an understanding, because there are a lot of these sheep around there. 300,000 men get diagnosed with prostate cancer, and that's the reason all this drama about the PSA should be done and not done. I will not go too further from here, and I will bring up the panel very soon. But my theme is PSA saves life. But not every elevated PSA needs a biopsy. Not every diagnosed cancer needs a treatment. And if it needs a treatment, I would rather find this cancer early when there are many options there. Sometimes I want to have a realistic expectation as to when can I save the nerve and when I cannot save the nerve. I really want to have a discussion about how the staging, how the PSA PET scan, how the MRI, how the new ultrasounds, all those things are helping me in making a decision choice. Which patient is not a candidate for surgery at all, which patient needs a chemotherapy or a hormone therapy. We are developing immunotherapies and clinical trials and all that matter. So at this point, I want you to imagine there are different kinds of prostate cancers, even though they carry prostate cancer in the word. But not finding a cancer in time makes me really disappointed and sad. Reason I'm saying it, we have launched a new initiative, and you may have seen a mobile unit which is outside, in which we send a van to every place where we can, the churches, the schools, and community centers. And I was hoping to reach out to about 1,000 men in 1 year. We just crossed 4,000 men. And out of those 4,000 men, 700 of them have an abnormal PSA. And many of them have a PSA which is above 20, above 30, above 400. I didn't want to see that. I would like to see a PSA of 5, 4, 3, 7, that kind of a number. So that means the same PSA of 500 3 years ago was a PSA of 6. I could have cured that. But if we don't find it early, we are not able to give the options which exist. So going and finding out is important. The biopsies have become much more safer, the infection rates have gone down, transperineal biopsies have come up, and that's what I want you to have a session today. So moving forward, we will have sections for people at risk, people who have had a negative biopsy, people who are deciding between active surveillance and treatment, people who are deciding between different forms of treatment, people who have had a treatment of one kind and have an early recurrence, and people who have a metastatic. And I will create subgroups over time so that you can talk to the experts in the panel. Not everything will happen today. But let's get the panel here and talk about what are the different methods of diagnosing prostate cancer, who needs an 4K, who needs an MRI, who needs a transperineal biopsy, who definitely needs to have a ExactVu Scan, who needs a genomic testing. First round we will focus on that. Then we will have a panelist who will talk about one treatment versus the other treatment, whether radiation is better, whether surgery is better, whether nothing is to be done. So let's get ready, but I want someone to come on the table, on the podium, who will highlight my passion about that. We owe a lot to the ladies for helping men in navigating. I really want to see next time more ladies in the room, because they will take the message out and they will possibly help us beat this battle better than what I'm doing. I want you to introduce yourself because you are a good speaker.
Thank you. Thank you so much, Dr. Ash. Good evening, everyone. My name is Seema, and I am the Executive Director of the United Nations Entity for Women globally. And I must tell you, that when I first met Dr. Ash, I was touched by his warmth, by his skills, and also by the fact that he understood where I stood with him in his clinic when my husband was being diagnosed. And he told me that you women are a major factor in recovery and in better care for all the men I am seeing. And for that, I really appreciated him a lot. I told him he is a he for she champion, which is an initiative that we at UN Women at the United Nations give. It's a title, an honorary title we give to heads of state and government, but I thought that he deserves that as well. So today, and what we usually do to do that, he told me that I should speak for 30 seconds only, but you know what? At the United Nations we can't except speak very long speeches. But I actually thinking of how wonderful you are to all your patients, and your reputation preceded you a lot. I'm happy to just present you with this very modest, it's a tie that says he for she, and that I know that you are a he for she, but you have also asked me that I should also work on a she for he as well.
I need many more she for he.
So we will do that as well.
So, Michael, you want to introduce everyone in the panel, and then let's get the panel, and I'll ask the questions, and questions you can ask too. So I will leave it. One person I will take for a minute, Dr. Menon, please. Dr. Menon is the legend. He is the father of the robotic surgery. He happens to be my teacher also. Dr. Badani is in many chairs in the United States. And we are lucky that he is with us in the department, and he helps us in navigating two things. He has a tremendous knowledge about management decisions part of it, and he is a pioneer in developing a new kind of a nerve sparing approach, which is known as the precision prostatectomy. So, Dr. Menon, thanks and welcome being here.
We're going to have two panels tonight, and we're lucky enough, as we've already heard, we'll hear from Dr. Menon. Along with Dr. Menon on the first panel, we're going to invite up to the stage Dr. Avinash Reddy, please. Dr. Reddy. Along with Dr. Reddy, please welcome esteemed Dr. Peter Wigland. And someone who will be joining me next week in Potsdam, Germany, to discuss AI and some of the innovations that we will be doing as part of the Department of Urology, Dr. Michael Gorin. And can I please, a personal friend, Dr. Wojcicka, please. Welcome, Dr. And last but not least, excuse me, Casey Schlissel, please, Casey.
So the second round, we will talk about a little bit more metastatic cancers, recurrences, and we will talk about the sexual rehab discussion. We have experts on both of them. The first round, we have people who have recently been diagnosed, the people who have questions about who should get a biopsy, when we can avoid a biopsy, who should be a good candidate for active surveillance. So Dr. Menon, I have a question for you. A patient with recent diagnosis of 4 course of Gleason 6 prostate cancer has a PSA of 7.5. What do you think that patient needs to do? How will you make a decision? What are those patient's options? And you can give some data about the recent publications which have come out of here.
So a Gleason 6 prostate cancer, by and large, is a very indolent or slow-growing prostate cancer. If you take 1,000 patients with Gleason 6 and follow them with no treatment, 970 of them will be fine, but 30 won't. Having 4 cores takes it from a very low-risk prostate cancer to just a low-risk prostate cancer. So these might be the 3% of men who will do poorly. Biopsies intrinsically are not 100% accurate, they're just sampling. So the first thing that I would recommend is don't rush in, don't get treated, wait about 6 months and then get another biopsy. In the meantime, you can get imaging studies, such as an MRI or a PSMA scan that will tell us whether something has been missed on this biopsy with some degree of accuracy. But the key driver is what the confirmatory biopsy will show. Mike Gorin has actually spent a lot of time studying this. He ran the active surveillance clinic at Johns Hopkins for many years before we were able to, Dr. Tewari was able to attract him back here, and you might have something to add.
Please, Mike.
Thank you, Dr. Tewari and Dr. Menon. I think I entirely...
Can I just take, this is Dr. Michael Gorin, who is our new Associate Professor of Urology. He was at Hopkins before. He is a master of the targeted biopsies. He's a master of transperineal biopsy. He ran the active surveillance program. And his practice is predominantly in Long Island. So anyone of you who is in Long Island area, that's where he lives.
Thank you, Dr. Tewari. I appreciate all that. I think I agree entirely with everything Dr. Menon has said. The problem with Gleason 6 prostate cancer is that when it's diagnosed on a biopsy, there's always the potential that there's undersampling of the gland and that elsewhere in the prostate there's a higher grade cancer. And anything more than Gleason 6, or what we now commonly refer to as grade group 1, depending on the life expectancy of the patient, by and large does need treatment. So the question is, can we do diagnostic maneuvers to prove to ourselves that we think that this patient most likely has Gleason 6 prostate cancer, and then we can confidently proceed with active surveillance. It turns out that the more cores that are positive, so the higher volume of Gleason 6 that's found on the biopsy, the higher the likelihood of reclassification, eventually being found to have high-grade cancer. Historically, that rate was probably about 10 to, what's that?
20 to 30%?
That's right, overall. And I was going to say for very low-risk prostate cancer, probably about 10 to 15%. And the vast majority of that risk was at the time of that second biopsy, the one Dr. Menon is talking about. And again, that was because you just take more cores of the prostate, so more of it now has been sampled. We are now in an era, though, where we have really advanced imaging techniques, which at the time of either initial diagnosis or that second biopsy could basically find all those errors of the biopsy. So what we're finding is that less and less men now are coming off of active surveillance. And so long as a targeted biopsy with appropriate systematic sampling has been done using the types of imaging tests that Dr. Menon talked about, whether it's at the first biopsy or that confirmatory biopsy, men stay on active surveillance now for a very, very long time. And I think we're going to see that 20 to 30% number come down significantly in the years to come.
So basically, a patient has been diagnosed with a Gleason 6 prostate cancer. Only reason the patient will have Gleason 7 prostate cancer are two. We didn't pick up the 7 which was there at the first time, what we call tip of the iceberg phenomena, and it happens in my own biopsies, so it can happen to any biopsy. It has been happening less often with an MRI-guided targeted fusion biopsies. It is happening less, but that's a possibility. That's one thing. Second thing is that over time it grew from in 6 to 7, and that is where the follow-up sequential monitoring becomes important. So how do we monitor these patients? So first time we did, so what is my protocol for doing an active surveillance? Patient comes with a Gleason 6 prostate cancer. First thing I do is to get it reread by my pathologist. Sometimes pathologists, 5% of the times, they change their mind. One's 6 is someone's 7. It happens. It's a perception discussion. So we check it out. I get an MRI scan if it has not already been done. And if MRI shows more impressive disease than the biopsy shows, then I think there is some disconnect, and I try to do an MRI guided fusion biopsy as a confirmatory. And third thing which I do is to do a special kind of an ultrasound scan, which is known as a micro ultrasound. And I will ask question about micro ultrasound to Dr. Vinayak in a second, so get ready for that. But I also like genomic testing. So Gleason scoring is a look of the cancer. Genomic is what's happening in the actual gene of that cancer. Sometimes good-looking cancers may have a bad-looking gene, and they may push the cancer to be more aggressive. And there are 3 different kinds of gene tests we can do. One is known as Polaris, other is known as ExactVu, and third is known as Decipher. I don't think there is much of a difference between 3. There are different kind of gene sets which we look at it. So we do one of those tests, and 80% of the times there is a concordance with what I think the Gleason is and what genomic comes out, but sometimes there is a disconnect. I don't usually change the course of the treatment just based the gene as shown it, but families do get nervous, and I get a little bit too cautiously following in that. But we can talk about those discussions. So between Vinayak and Casey, what do you think is the importance of an ExactVu Scan, which is a 29 megahertz micro ultrasound, which looks something like this? So look at the resolution of this picture. The normal ultrasounds are 5 megahertz, 7 megahertz. This is in high resolution 29 megahertz picture, which gives a little, they call it microscopy level, but it is in higher resolution than the conventional ultrasound. So we do that, but the beauty of it is it can be repeated and it can be done by the doctor's hand, so we can focus on the area which we are concerned. So Vinayak and Casey are leading that program here, so please.
Yes, thank you, Dr. Tewari. So this is called micro-ultrasound. Dr. Tewari already summarized. Conventional ultrasound that we used to do it 5-6 years before, it has a resolution of around 4 to 6 megahertz. Resolution is the picture quality, how good, how details you can see the prostate. So that has been increased to 4 to 6 times now, 29 megahertz. You can see very much details. You can see some dark areas looking like a cancer, bright areas looking like calcifications. There are certain things that we can look very carefully. And the major advantage of this micro-ultrasound is real-time imaging. So the urologist will be able to do it. He will be able to talk with the patient at the same time in the clinic, and he'll be able to tell, you have this lesion at this point, it is how much close to the prostate capsule, and it is either going out of the capsule, it is pushing the capsule, or something is happening to that area. So not only detection of cancer, but how aggressive the cancer is growing. Dr. Tewari said we can monitor it. You can do the ultrasound every 3 months or 6 months, so that if an area, abnormal area that was there 5 millimeters, 6 millimeters, after 3 months, if that 5 millimeters go to 7 millimeter or 8 millimeters, it means that something is happening in that area. So it's good to have a proper discussion with the urologist, and the real-time imaging is one, I would say.
It also becomes very important in patients who have a pacemaker, patients who have some kind of metallic thing, and the patients who don't like getting into the MRI board. I do both, but in those patients, they definitely need to have something of this kind. It helps us in identifying the area which is of concern. But there's another area, and I'm jumping my steps here. Some of these patients need to go to the operating room, and you can see that the black line in the bottom is the capsule of the prostate, and just outside the capsule are the nerves. So, can this ultrasound pick up possibility of breach in the capsule? And that's where Casey's role comes, because Casey does them in pre-op, and she is also assisting me in an operating room for the last 10 years. So Casey, what is your experience within micro-ultrasound and for that indication?
I think what's great about the micro-ultrasound is that in real time, I'm able to see if the lesion is, like Dr. Bananek expressed, is breaching through the capsule. And if it is, I can measure the millimeters. So at the time of surgery, Dr. Tewari knows in that area, he has to cut a little bit wider. In that area, the nerves are infected with the prostate cancer, and they're no longer the patient's friend. It's a great planning tool.
So, active surveillance patients are getting sequential what? Dr. Menon, what is our protocol and how should we manage it?
So the protocol that we are trying to implement is that if you are being followed, and usually you have a Gleason 6 cancer, we want to make sure that it doesn't become a Gleason 6. You'll be seen, we'd like you to be seen 4 times a year. Once a year you'll be seen by Dr. Tewari himself and his team. Once a year I'll be seeing him as a surrogate for Dr. Tewari. And twice will be seen by the nurse practitioners or the PAs. Marla Gabriel is the PA who's who has expressed desire in controlling this. Once a year you'll get an MRI. Once a year you'll get the ultrasound. 4 times a year you will get a PSA. Once a year you will get a rectal exam. You may get a new test called a PSMA PET-CT depending on what the MR shows. So we feel fairly confident that, in fact, we feel completely confident that we'll be able to pick things up with a 3-month delay at most. And that's between one visit and the next visit with this kind of follow-up.
So I have at this point, based on the last analysis, close to 12,000 patients who I have not operated on. So I have operated on close to 10,000 patients, but about another 12,000 I am following in one form or another. And as you can see, I have a vision for how to follow these patients up. So genomics is an important part. I don't like doing too many biopsies, so normally I do what I call a no matter what biopsy 3rd year after they have been put on an active surveillance. But I will do a reactionary biopsy if the patient shows a progression, and the progression or the trigger is patient's PSA goes up too high. But not only one thing. If PSA goes up, it could be infection, it could be something else also. If patient's MRI is showing something concerning, these are the 2 reasons when we worry about it, and that's when we escalate it to an earlier biopsy and all those things. We do 2 kind of imaging, MRIs and ultrasounds. I'm slowly incorporating with the due blessings from the insurance companies about the PSMA discussion. My hypothesis is that if a tumor is not visible on a PSMA PET scan in the prostate, it's unlikely it is a bad kind. So, but it's not in the standard of care, and some of the things we talk about it, don't go and talk to the other doctors, they may not be able to do it because that's still not the standard of care, but that's where the field is evolving, and I'm sharing some of the ideas which we are doing it. I think anyone else has a question about the active surveillance part of the discussion? Please, go ahead.
Okay. I had an MRI several weeks ago. When I arrived for it, I was told that because I had bilateral hip replacement, that I could not go under the high resolution and instead did the
1.5 Tesla.
Exactly.
Yeah.
Is that a waste of time?
No. 1.5 Tesla went out. 1.5 Tesla MRI was the standard of care in Europe for a long time. So I think it's a good one. And you should definitely look at it, what it shows.
It didn't show a lot.
Didn't show a lot.
But
What's,
biopsy did show something it does not appear to be aggressive, but obviously the reason I'm here is because...
So one of my colleagues, Dr. Vinayak, who just talked about an ExactVu Scan, has just published a paper. It's known as stealth tumor. So nothing in medicine is perfect. 18% of the prostate cancers are not visible on an MRI. So, and especially an MRI which is not. So what is an stand? Let's spend 30 seconds on an MRI for now. MRI is in magnetic resonance imaging, and for prostate it is known as 3 Tesla multi-parametric MRI. Multi-parametric, what it means that there are 3 different components of that MRI scanning. One is the T2 weighted images, second is in how water molecule is moving, what we call it diffusion weighted images, and the third is how rapidly the contrast is coming to the different parts of the prostate. So that is a multi-parametric part of it, and this is how it looks like. You get a scale of, I like simplifying it, so don't look at the dark pictures, look at the apple. So basically pyrite scoring is given, and sometimes nothing is seen and still 18% of the patients may have prostate cancer. That's what so you had a good doctor who still went ahead and did the biopsy. So that's right. But now what you have to look at it, what's your PSA, what percentage you have, do you have all 6 or are there some areas of 7? You don't have the biopsy result.
Yes, the biopsy indicated some activity. I'm meeting with my doctor next week.
Sure. So, but these are the questions you need to have, and then you can, if it is 6, and I must say I have 20% of my patients who are on active surveillance, they are not 6, they are 7 also. So some 7s can also be on an active surveillance, but I'm keeping things simple for the first round of the discussion. And so that's what I think we need to do on an active surveillance side of the discussion. Anyone else has a question about active surveillance? Please, go ahead.
I would just like to ask, because I'm 7 and I'm on active surveillance.
Yeah.
I got diagnosed last year, so do you recommend, is there a certain amount of time that you stay on active surveillance?
So I have a...
You just keep going by your biopsies.
So if you are on, you look very young. So my take of the active surveillance for Gleason 7 is on the both extremes. Meaning, first of all, MRI should not be bad or impressive. PSA should be 7, 8, 5, something like that. It should not be 90% Gleason 7. There shouldn't be a Parat 5 lesion abutting the capsule. If those things are not there and your genomic is a low risk or an intermediate risk, I think you can be on an active surveillance for an extended period of time.
How long roughly do you think?
I have personally patients who have been on active surveillance for 7 for at least 5-6 years.
So let me...
Dr. Menon has a data point.
I may have a slightly different viewpoint. There's no question among anyone that if you have a Gleason 6, you should be on active surveillance. It doesn't mean you go away for a year and don't come back, but you should be carefully monitored. The jury is out on Gleason 7s. Many Gleason 7s won't progress, but about 30 to 40% will progress. So if you have Gleason 6, the chances of you progressing is maybe 10% with a good biopsy. But if you have a Gleason 7, the chances of it progressing are more.
30 to 40%.
Unless you get new data that says that the existing data is not. So a Gleason 7 on active surveillance, we would say it's uncertain value, and we can't say that there's going to be a 97% chance of you not doing well over 15 years. That data does not exist.
What Dr. Menon is saying, Gleason 7 active surveillance in a very young man, a little bit nervous. But there is a benefit, no sexual side effect, that's the reason we do it. So it comes with a little bit anxiety both sides, so don't miss the appointments. We have a very technical point on this thing, oops moment. Don't let your cancer become not treatable if you are on that pathway. I have hundreds of patients on active surveillance who are Gleason 7, but we are nervous, so don't miss your appointments. Make a prioritization, what is important, stay connected to your doctor. That's how I'll approach it.
Now, where we may be going is, if you have a Gleason 7 and it's a very early Gleason 7, maybe you don't need the whole prostate treated. Maybe you can just have the cancer treated, if we can map it accurately. But that is still under evolution, but it is a very good thing to consider, because the side effects of treatment of the whole gland are not seen with partial gland treatment.
You definitely should get that genomic test.
I have a point that
we'll get to you. There's one behind you first, then I'll come to you.
Ash, can I just say something here?
Please.
There is a large study from
before
UK.
you do it, you will see in this room, my own department, they will be having a different opinion, and that's what I want you to hear. Some of us are proactive, some of us are not. So you should be, I'm open to having that discussion with everyone. So go ahead.
So I just want to say something about the PROTECT trial, because there's a large trial from UK where they were randomizing patients to active monitoring, radiation, or surgery. And in the active monitoring arms, almost 65% or almost 70% of patients had active treatment within 15 years. So when I see you're young, so you were actually very high risk to become treated at some point. So you should really, as Dr. Tewari here is saying, that you should go to your appointment, because you're at relatively high risk if you're a Gleason 7, that you will reach the point where you need some more active treatment.
That's a very good point. It's a new trial which has come out in one of the major journals. I didn't introduce Dr. Wicklund. Dr. Peter Wicklund is a personal friend of mine. He is one of the best bladder cancer surgeon who does robotic intracorporeal. He's also a very good prostate cancer surgeon. He led the program in Karolinska. He has been instrumental in collecting the data from the Scandinavian trials. I reach out to him when there is a more extensive lymph node dissection discussion. Because of his experience with the bladder cancer, I have him, Dr. Reddy or Vinay, but he is the top of doing those kind of things. So I just wanted you to know who is Dr. Wicklund. Go ahead, please.
So I think I just got my question answered. My question was going to be, what % of active surveillance patients ultimately require active treatment?
Yeah, I think over 15 years, according to PROTECT trial, Dr. Wickland thinks 50 to 70% of the cancer. But I am more reluctant. I mean, I'm trying to be the gentleman surgeon discussion. If we do it right, and so for you, both of you are very young, I'll say one thing. And I have given that story to some of the people, but I'll say it in public. In 1993, when I came to United States, I had my 2 kids and my wife, and some guy who knew my father-in-law gave me $500. I still remember that guy because that $500 meant a lot. So 10, 20% risk of sexual function problem at your age versus 10 years later, you do the math. That's how people decide. So same risk at a different time in your life may mean something different to you, as long as you don't jeopardize your risk of success cure. That's how I would say it. Does that connect with you? Yes. So, sorry, just in a second, I've seen you were asking.
Well, a lot of my questions have been answered, and I don't want to use the microphone.
Okay, that's fine. Say it loud.
Okay. It was about the, what is that? That scoring, 6?
Gleason 6?
The Gleason 6 score. When you do a Decipher test on a person with a Gleason 6 score, and you have that result that it may be an aggressive cancer, would you, none of the doctors I saw, and I saw 3 before deciding on who I want to go with, recommended anything, right? I just knew what they did. But would a prostatectomy be recommended knowing that they have the likelihood?
So very rarely I will recommend an active treatment just based on one test, but I just get more NC, I will do more frequent biopsies, I might do more PSAs, that kind of a thing. And I tell the patients, and patients decide. But I will not say that you need a radical prostatectomy because you have an intermediate risk prostate cancer. If it's in high risk, it's a different discussion, but you factor in all of that, then your gut feeling will tell you whether you want to do this or that. And I really fight hard for low risk, very low risk cancer with an absolutely normal PSA, absolutely Gleason 6, 5% cancer. I really fight for it, meaning.
And then like the results of a Decipher test, how much does that come into play on if you have the biopsy, you get your Decipher test somewhere else down the line? Because I was about to do radiation treatment, right? And then I decided to have a prostatectomy. But when my radiologist called me and told me about the Decipher test, he sounded somewhat relieved that I was moving forward with the prostatectomy.
You may have had an aggressive phenotype in your Decipher test, and so out of 100, 2 or 3 are annoying, which are not going according to the plan which I thought they will show. That's where it becomes individualized discussion. I will tell honestly to the patient, I don't like it, I don't think you need to do anything, but you can decide to have it.
Can I relay a funny saying that I heard once about the use of the genetic tests? So realize that as we've conveyed here, people who have Gleason 6 prostate cancer, it's a very low likelihood that they will eventually progress in terms of their prostate cancer. So very few people who we end up doing that Decipher test on do we really get very useful information. So many urologists, or some urologists, are split and don't really use that test a whole lot because it's been said that urologists use the molecular test the same way that a drunk uses a lamppost. He uses it more for support than for illumination. And so it's just one piece of the puzzle here, right? It helps illuminate some information. It helps support, the doctor's notion about your case, and collectively puts it together with the other parameters to make a recommendation. Very rarely, in men with Gleason 6 cancer, is the Decipher the illuminating factor.
Especially if it is 7, and if it is more aggressive 7, then I'll say, you know what, there's something not right. You already have a Gleason 7, and your Decipher is also saying something. But Gleason 6, I will fight a little bit. Go ahead, please. Sorry.
Some of the questions were already answered, but I just to reiterate, what would be the treatment options between, say, a Decipher score of 20 versus a 90?
90?
90.
Okay. So let's look at what is a Decipher test. Decipher test predicts what's the likelihood that this patient's cancer will come back 5 years, 10 years from now. And that Decipher, we used to do it in the radical prostatectomy specimen, now we are doing it in the biopsy. So basically, you should consider aggressive treatment, which could be either radiation or radical prostatectomy, and with a very close eye on doing a PSA every 3 months for at least couple of years, because the likelihood of PSA recurrence goes up. That's where, but this brings a discussion about maybe radiation versus surgery discussion. Is that right? I think I will leave it to Dr. Menon and Peter. And Peter, what do you think?
Yeah, so this is a very complicated question, unfortunately. So we know that there are very different side effects from
By the way, there is no Dr. Stark here.
No.
So be fair.
Yeah. So urologists and radio-oncologists don't necessarily have the same opinion about this. But so the side effects are very different, of course. So that's number one. But I have done, so I'm from Scandinavia, where we have long register, and we have followed patients with prostate cancer for many years. And if you look into prostate cancer mortality, which is just, the risk of dying from prostate cancer, or actually patients that die from prostate cancer, and it's very few patients that get prostate cancer who actually die from prostate cancer. So that's number one to remember. So most patients don't need treatment, okay? And that's why we are talking about Gleason 6 and 7 and 8 and so on, because there's a lot of patients that will have a diagnosis of prostate cancer, but they will not die from prostate cancer. But if you look on inpatients that die from prostate cancer, and you look at the different treatments, radiation and surgery, first you have to study for many years, because most patients live for 15, 20 years. So if you look, like many studies nowadays look for 10 years and look at prostate cancer outcome, they only can measure biochemical recurrence, which is the recurrence of PSA. And that's very different after surgery and radiation, because after surgery we can pick up a very low PSA level. Most of these are insignificant. So if you have a high risk biochemical recurrence, so that what we call a high risk, you have less than 10% risk of dying from prostate cancer in 10 years. If you have a high risk recurrence after radiation, you have 50% risk of dying from prostate cancer within 10 years. So that in my studies, I see that prostate cancer mortality is almost twice as common after radiation compared to surgery. When we try to adjust for all the difference, Gleason, PSA, all the things that we know. So my opinion is that the best oncological treatment is surgery for most patients. But then, if depending on your age, so the younger you are, the less, for me, is to recommend radiation. You should have surgery if you're like between 50 and 60, and then when you go older, especially if you go up to like 75, then you don't have time to develop the long-term side effects of radiation, or you're less likely to do that. So then radiation is better treatment for the older patients. So that would be my opinion.
So I think we had a little discussions about active surveillance. It looks like room is happy with the active surveillance discussion. Any other questions about the treatment choices, HIFU, focal therapy, anything of that kind anyone has? Please.
Yeah, I'd like to know more about the focal therapy for if you have Gleason 7.
Sure. Mike and Ali.
I don't think Abby's had a chance to. So, focal therapy is something, when you're deciding on what kind of a treatment you're going to do, you have options of surveillance, you have options of doing a whole gland therapy, whether it's surgery or radiation. You have options now of doing a focal therapy where you only treat the area that has the cancer. And, it depends a lot of it on what's important to you. If you think about it, if you hit something, if you have a cancer you need to treat, say you have a Gleason 7 cancer, we decided we're going to treat it. If you do a more aggressive treatment, the chances of having any issues down the road with the PSA recurrence or cancer coming back are very low. But at the same time, there may be more side effects. If you use a smaller treatment, then chances of having cancer come back are a little bit higher, but you have less side effects up front. And so that's kind of where that discussion comes in. You know, if you're considering a focal treatment, it should be a disease that's in one area of the prostate, or at least some areas that are continuous.
One half.
One half. One half, whether you...
One half is a better option, and not close to the front and apex is a better option. These are the simplified version of the discussions. So there are different kinds of focal therapy, and I'll have Dr. Gorin say in a second. There is a high intensity focused ultrasound, in which we use an ultrasound machine to zoom in the beam, and beam produces at the focal point heat, and the heat causes coagulation necrosis. There is in cryo, there is in laser, and there is in IRE. These are the 4 known forms of focal therapy, and we have them here. We are trying to start a clinical trial in which we are injecting an immunotherapy agent into the tumor, and that is based on a neoadjuvant study we did, and we are hopeful that that will keep the cancer 7, not become 8. So that's another kind of a trial which we are doing it, and we are doing it with HIFU and immunotherapy agent together. Why don't you expand on the indications, what are the problems, what is the likelihood of success, that kind of thing.
Yeah, I mean, even going back to the active surveillance discussion, everything we've talked about tonight is a balance of risk and benefit, right? Active surveillance, we could treat everyone with it to prevent those, as Dr. Menon said, 30 in 1,000 cases from progressing, but the morbidity of doing so is very significant to those 1,000 men who have been retreated in the way of urinary complications, inability to, say, control your urination, or loss of erectile function, right? So that's why we don't do that. It's a very clear demarcation that the oncologic risk is so much lower than the morbidity of the treatment. We start to get into a gray zone once we hit Gleason 7 prostate cancer. We've already heard one gentleman talk about how he was offered active surveillance for that, and Dr. Tewari confirmed that he does indeed do that in his practice. Certainly if you have a very high-risk prostate cancer, 8, 9, 10, it definitely makes sense to have it treated because the oncologic risk, the risk of that cancer spreading is so much greater than the potential side effects that you'll have. So for men who find themselves in that gray zone, we offer subtotal prostate treatment, focal therapy if you will. There's even now surgical approaches where we only surgically treat part of the prostate. Dr. Menon has pioneered the technique called the precision prostatectomy, and it all just comes down to the balance of those 2 risks. So I would say, on average, the side effect profile of focal therapy is such that really no one leaks urine afterwards. There can be some erectile dysfunction, but it's probably half of what it is with whole gland treatment in the form of radiation and surgery. With that said, most men with Gleason 7 who undergo whole gland treatment with radiation or surgery are cured and never need to think about their prostate cancer upon being treated beyond just monitoring the PSA level. With focal therapy, that's not so. About 20 to 30% of patients will, at subsequent surveillance, be found to still have prostate cancer and will need additional treatments. We believe with close follow-up that we can salvage that situation and then at that point in time deliver maybe another focal treatment or move you on to whole gland treatment. But there is always that risk that we can miss that opportunity, especially if a man doesn't follow closely with their doctor. So that's the risk there. We've got a lot of technologies to do it. The way I think about the technologies is there's 1,000 ways to skin a cat, right? At the end of the day, what we're doing is we're killing that massive prostate tissue. Do we freeze it? Do we burn it? Et cetera. And a lot of it comes down to what is the right tool for the job. Some people talk about using HIFU for posterior tumors, cryo for anterior tumors, and so forth. You want to find a surgeon that you trust, that you see, you understand each other's, that he understands or she understands your priorities in terms of cure and side effects and so forth, and allow them to choose what they feel is the right job to achieve the goals that you set out for yourself.
Anyone else? Yeah, please.
Yeah, just wanted to know the percentage of people who develop incontinence.
About 5% patients on an average develop incontinence after nerve-sparing radical prostatectomy. Focal therapy less than 1%. Radiation therapy close to 5% or less. If someone is older, someone has more cancer, someone has some neurological issue, someone has blockage, someone has a very big prostate, it can take a little longer and a little higher chances. They are the one who will need a sling or something of that kind. But on an average, about 5% of the patients are good. And there are things which we are trying to change, improve, modify, because these 5% they exist. So, please.
What percentage of men over the age of 50 are having their PSA checked annually?
I think it's a my question.
In this country? I don't know the answer in this country right now.
I think
a range.
About 30%.
30%.
You think that well?
Yeah, it's low. It's 70% of people don't. Any study that we
actually, I may be, Dr. Menon, you're very close to 30-40% because I read a data recently in which black men were 3% lower than Caucasians in that testing rate. And it is 30 to 40% range it was, and they were a little lower, so we were more concerned about that they have a little bit more aggressive cancer and yet they are not testing. So there is a lot of opportunity for us to.
In this PROTECT trial that Dr. Vikram was talking about, 200,000 men were offered free PSA testing and 120,000 refused it. So that's, so even when they were contacted and said, come and get a free PSA, in the UK, where people generally listen to their doctors more than in the US, most men did not get it. So that's why I think 30% would be an estimate.
I have a feedback response for the rest of the crowd.
That's organizations.
So,
this organizations, not.
So we did this 4,000 men with a PSA testing, and this was free PSA, which is 700 of them had an abnormal PSA. Couple of hundred of them, we are trying to chase them out, come back and get something done, and they are not responding to us. So I am now looking at free phones. Some of them didn't even have a phone with them so that we can reach out to them. So it's very difficult to break that barrier. We got the first PSA. We know that they have an abnormal PSA. Now my team, I'm driving them nuts as to, you have to, I mean, even thought about send a biker to their home, but men don't respond. So getting a PSA done is important. Not every PSA needs an intervention, not every biopsy needs a treatment. But not knowing it and then finding it when it's incurable, that makes me sad.
Well, I'm amazed at how many men over the age of 50, particularly that are well educated and should know better. Some don't even know what the acronym PSA.
Please stay alert.
No.
That's what it means.
I'm just saying, they don't even understand, most people know it's associated with the prostate.
So there is a reason for it actually. About 5 years, 6 years ago, there was a confusion between the medical community and the lay media that PSA was being interpreted and reacted to a little too strongly. So this is a balanced part. So it's just not one part of the equation. Sometimes we may have done little too many biopsies, or maybe we make people more anxious. Right now the balance is, if the PSA is rising, PSA is elevated for the prostate volume, that's when we should. I mean, there are many more testings. I mean, I have slides on, and that's the reason I'm waiting for someone to ask questions about those things. Please.
So even looking at patients with active surveillance, and this is a nice experiment that was done in Michigan, where Blue Cross and Blue Shield is the main insurance provider. And if you follow the guidelines, the doctors in the hospitals get paid 3% more. And if you don't follow the guidelines, they cut you by 3%. So this is a powerful incentive for all the urologists in Michigan to follow uniform things. Taking people who are diagnosed with prostate cancer, which is far different from the random person who doesn't even know he has prostate cancer. Only 24% of the men got a PSA every year.
How many?
24%. Were following the protocol. When I did an audit when I first came here with Dr. Tewari's patients, where not all of them follow with Dr. Tewari, some of them go somewhere else. And I tried to see what percentage of people got a PSA every year for 2 years. Out of 5, I found 19% here. So the 30% that I said was an optimistic estimate. Probably it depends on who they're married to, you know.
The second question, follow-up to that, is if you're fortunate enough as a male to live to be 80, what percentage of men that are 80 years old will encounter prostate cancer?
Pretty high number, but not that, as we talked about, not every prostate cancer is a real cancer. They have cancer. And then you just respond and acknowledge, nod, create a plan. But I've seen Gleason 9s also, an 80-year-old guy who runs marathon. It's a different person. So please.
Yes. First question is, what is the recurrence rate between radiation versus surgery? And what would be, and the second question is, assuming a recurrence in the aspect of prostatectomy, what would be the follow-up treatment after that?
So I can make it easy that if the PSA recurrence happens after radical prostatectomy, 9 out of 10 times it is treated with a radiation. Sometimes it's a targeted therapy based on NPS, PET scans and all those things. But after radiation, things are a little bit tricky. I end up operating on some patients who have had radiation and what we call a salvage therapy. Their incontinence rates are very high. I have not had, I've been lucky, but there is a known fistulas, there are known rectal injuries, and sometimes second cancer discussions happen. But after radiation, things get a little bit complicated. So most of the time you end up having either cryotherapy or salvage therapy or hormones.
Simply, after radiation, about 0.5% of patients will die of prostate cancer every year. So over 10 years, 5% would die. After surgery, maybe 1/2 of that, or 2.5% to 5% will.
Isaac, what's your question?
Hi, I was a Gleason 6 for 1 year, and then I went to a Gleason 7, and we decided to do the prostatectomy, which was successful. So my concern is, if your PSA is low and you are doing well as far as your PSA is low, what is the return rate over a lifetime period of recurrence of cancer coming back?
Should there be a disclaimer from you that you are a scientist and a researcher? I know him. so his questions will be too complicated for the rest of the. But
I'm sorry. It's just an overall thing that I was successful. I'm cancer-free now because of the plan that we decided to follow with the prostatectomy. But I just overall wanted a picture of what it would look like, maybe.
I mean, I think these 35,000 men, they exist right now, that every year we are losing them. And they are not dying they are dying due to prostate cancer. But the big number is about 300,000 we diagnose every year. So there are some patients who will have a bad outcome if we don't intervene in time or we don't find them in time. But majority of men, we can be cautious, deliberate, not so aggressive, and do the least we need to, which will not burn the bridges for the future man. That's the theme we have to take in. We evaluate our priorities, we evaluate our life expectancy. I have patients who are 76 and running marathons and physically fit. One thing I didn't tell you guys about that active surveillance means we do the surveillance and you do the activity. By activity, I mean eating right, exercising, and I'm very nagging. I will keep talking, and I have one visit which we didn't mention about is Jillian. Jillian will talk about the diet, nutrition, mind, body discussions and all those things. So it's a lifestyle commitment, you have to make it. And but let's not just get into one side. Who else has a question, please? Go ahead. I think I can tell you I cannot see you guys because of the light on my face. So if I'm not ignoring someone, it's because it's just I'm not seeing you.
Okay. What about the hormone therapy? Is it working or is it not? How long are you using it for the patients?
So hormone therapy works. First guy who started became a Nobel Prize laureate. But yes, so generally most cancer cells will die when you start hormone treatment. But it will only work for so long. And we don't know beforehand. Sometimes it works for 20 years, sometimes it works for 5 years, and sometimes even shorter. But most of the time you have a very long life expectancy, even if you have a metastatic prostate cancer, because almost all, but not all, cancers will respond to hormone treatment.
New kinds of hormonal treatment coming out. So one of the challenges with hormone therapy is initially it works in almost everyone. Then few years later, the cells start figuring it out and they develop resistance, what we call castrate-resistant prostate cancer. But there are newer medications coming out, and we have Bobby Leon, Dr. Matt Garsky, and other people who can help in finding the newer kind of a treatment. So it's not, one battle loss is not, it's a 12-round game. It's not just the first or second round of this discussion. So don't think that it's very disappointing. Please. In a second, let's, yeah.
Doctor, I was wondering if you could share your thoughts on the ExoDX prostate test and what role it would play, if that's more for diagnosis, if that's something you would use in active surveillance. Thank you.
Vinayak, you want to take it? Or?
Is that a genomic test?
So this is ExoDX.
Okay.
So prostate cells, when they are abnormal, they secrete something which is known as an exosome. It's like a cargo which they send outside the cell itself. So cell is living, but they send some small packaging outside, and in that packaging they have their most important things. Their DNA, their RNAs, and the most important. So that is known as an exosome. And when it comes out of the prostate, it kind of finally finds its way into the urine because semen finds its way into the urethral passage. So exosome is an urinary PSA which tells us that what is going on in the urine. So I do exosomes if it's a borderline PSA. If the PSA has already been tested, patient has a negative testing. Exosome and select MDX. There are two different tests which are done in the urine. Exo needs no rectal exam and select MDX needs a rectal exam. Both are pretty good tests, but again I don't take it. Basically decision is, does the patient needs a biopsy or not? And does the patient needs a second biopsy or not? So I will use it in a patient has an absolutely normal MRI. ExactVu is normal. PSA is 4.6, already had a biopsy, and what to do with next. So I'll do an exo. If exo is also showing something, okay, we have to do something. Patients already had a negative biopsy, I run another kind of a genomic test. That's known as confirm MDX. That confirm MDX can be done in a negative biopsy. It's technically what is known as an epigenetic test. And if it is positive, it predicts that the likelihood of a second biopsy being positive, so we do it. Patient has atypical cells, but not a real diagnosis of cancer. Patient has ASAP. Patient has high-grade PIN. Patient's PSA is climbing up and everyone is freaking out. That's when you use the EXO, select MDX. There is another test, 4K. So these are the different tests you use to decide who needs a biopsy or who needs a second biopsy. Does that answer the question? And it's very easy to do it.
Thank you very much.
Please. Please.
I already had the surgery, but this seems to be a seminar of people who get it.
No. We have people who are here who will talk about the sexual rehab and all those things. Dr. Taylor is here. I deliberately have him, but there's so much of excitement with the first round that I'm not able to empty the podium right now. Ask questions and they are here, they will answer it.
But I'm saying, what is life expectancy?
Are you looking good? Let's think about it. So my usual response in you kind of a thing is, we'll have a dinner in 10 years. But exercise, eat right, do your PSAs, those is the important thing. Don't get anxious. Diabetes, blood pressure, all those things still need to be tackled, and finding a purpose. I think you're good.
I have some simple questions.
Please.
What was the focal therapy I believe it was called? What is freezing?
Cryo. I think Dr. Gorin is an expert. So we have a beauty of it. I do HIFU or a robotic prostatectomy. Dr. Reddy does a lot of HIFUs. Dr. Mike Gorin is an expert on the freezing part plus other things. And we have got someone else who does the IRE. So we have experts on everything which we can talk, but cryo, Dr.
I mean, essentially with a patient under anesthesia, we use an ultrasound to locate the area of the prostate that needs to be treated. And then a needle is placed through the skin into the prostate. That needle is connected to a tank of argon. And when you pump argon gas through the needle, once the gas gets to the tip of the needle, it turns into ice very quickly. And so we can get our temperatures down to about minus 120 degrees. And we know based on the settings of the needle and the gas, how far that ice is going to expand and in what geometry. So we basically give a portion of the prostate frostbite, if you will, and it dies, and with it the cancer goes away.
And my second quick question is that I thought, when I saw my email, it said 7:30, so I planned it 7:30. Is there going to be another seminar?
So that is the work in progress. My plan is to have a monthly kind of a session or 6-weekly session, and we can have manage that it will be in post-op, it will be metastatic, it will be active surveillance, it will be at risk, and I think this is, what do you guys think? Is it useful first of all? And so answer is yes, there will be another one which will happen, and the same email group should be, I will try to, and I will respond to the feedbacks. I mean, I think what we can do better or different, but I do want 2 of my colleagues who are here, Joe and Dr. Tewari, come on in here for a second. I want you to be on podium. Dr. Menon, you don't leave. I'll get into trouble. We have another person who somehow I couldn't get today, Dr. Neil Grafstein. He is the master of the post-operative incontinence discussion. But these 2 people manage the sexual rehab part of the discussion. And by the way, if there is a question unrelated to them, they are not going anywhere, they are going to answer it. Peter, don't try to sneak out. So, any other questions first of all anyone has? Please.
I have a question.
Yeah.
It seems to me like reactive surveillance is a question that a lot of people that are diagnosed with prostate cancer struggle with. So within the last 20 years, have your opinion of basically you have a better idea of who better qualified to be under active surveillance, because it's a gray area that I went through that process when I was diagnosed when I was 48 years old, and I was like PSA 4. And then biopsy came out like 6, Gleason 6, and I was in that 2 years span, I was in, and then when the decision was made that I had to get surgery. So
I think your age was your I was against you. I mean, I think the youngest person I have operated upon was a twin brother, 36 years old. So young age is the main reason, but an ideal candidate for active surveillance, ideal, there is always ideal and there are variations, is a Gleason 6, less than 3 cores positive, none of the cores have more than 35-50% cancer, PSA is less than 10, and MRI doesn't show anything extensive, PIRAT 4 or 5 touching the capsule, and preferably genomic score is low. That's my ideal candidate. Dr. Menon, what's yours?
Mine too.
I have a question.
All right, thanks.
I just want to ask if the result of the PET scan must change the intervention.
No, I'll come to that in a second. There was a question from this side. But the question here is, does the result of PET scan makes a difference? So I want to dwell upon 30 seconds on a PSMA PET scan, which now has become available, was not available till about 2 years ago, and the PET scan didn't mean that it was the PSMA PET scan. That was not good for prostate, but the PSMA PET scan is a very good test. When the PSMA PET scan is indicated, PSMA PET scan is indicated in patients who have, at this point, based on the standard of care discussion, patients who have had a treatment and have a recurrence, or a patient who has an aggressive prostate cancer and may have micrometastasis. These are the two usual situations. But I've been pushing the envelope a little bit. I'm trying to explore more options. There has been some exciting data coming out of Europe and especially Australia that PSMA PET scan can add value to the biopsy. So simplified version, again, it's not in the standard of care. My hypothesis is that if I do a PSMA PET scan and PSMA PET scan doesn't show at all anything on the prostate, I'm not talking about in the lymph nodes elsewhere, I kind of get relaxed. This cannot be a bad cancer, that it is not even showing. But there are values discussion. There is an SUV values of 2, 3, 4, 5, 6, 7, 8, 9. There are a lot of mathematical discussion, but if it is visible, then I think there is something there, but it's not outside. But if it is nothing visible, then I may think maybe we can have an active surveillance discussion. But again, this is not a standard of care discussion. This is a scientist thinking few years ahead. Hopefully it will be true. If not, I'm using it in that. But if someone has an aggressive cancer, I will do it, and then I'm using to find out if there is a lymph nodes or something. I have patients who have a PSA of 20 and had 3 biopsies and nothing is shown. I'm worried there is something hiding. I'll do a PSMA PET scan. And if PSMA PET scan doesn't show anything, I at least feel, okay, maybe there is nothing. That's the logic. There was a question from this side. I wrote it. Anyone else? Yeah, please, sorry.
Could you clarify, what is the micrometastasis?
So metastasis means the cancer has left the prostate and has gone to the lymph nodes or to the bones. And metastasis was picked up by 2 conventional tests, which was a bone scan and a CAT scan. That has changed in the last 2-3 years. So if something is not visible on a bone scan and CAT scan, still the PSA is high. That means it is something small that the CAT scan and MRI and bone scan has not picked up. We call it micrometastasis. That nomenclature is changing off late because the PSMA PET scan is kind of finding some of these things which are now visible because we have a better test. So micrometastasis means it's a small cell population which has escaped the primary organ and is hiding somewhere else. We don't know where, but we think it is somewhere. So, please.
What would cause an elevated PSA if there is no cancer?
So PSA is a chemical which is produced by prostatic glands, and it is supposed to liquefy the semen when semen reaches the female birth canal so that the sperms can swim freely, go to the ovum. That's the PSA's role. PSA is produced by the cell and it is supposed to be secreted out. If cancer happens, then the cell architecture gets deranged so the cell's face is facing backwards, So the PSA produced is not going into the semen, it is going in the backside, and the backside is where the blood vessels are. So the PSA produced is not escaping, rather getting absorbed into the blood, so the PSA level goes up in cancer. But there were supposed to be 5 billion prostate cells in a person. Because of prostatic enlargement over time, that 5 billion became 20 billion, but there's no cancer, just that the PSA producing cells have increased. So we call it PSA density. Bigger prostates will produce a bigger PSA. Prostate is not supposed to be inflamed. But if prostate gets infection, inflammation, more blood supply comes, the same amount of PSA finds its way back into the blood. So it's known as an inflammatory reason for a PSA. So patients who have had rectal exam, patients who had erections or sexual activity, patients who had prostatitis, their PSA can go up without even having a real cancer. And that is where the art of finding whether it's because of cancer or not, that comes in. Please.
At what exosome score is an initial biopsy deemed imperative?
So they have, I don't usually use, if it's anything is above 60-30, that number is when I start getting nervous about it. But exo, without everything else normal, you repeat it, sometimes you check it out. But if it's abnormal, you need to get into a rectal exam discussion, you need to have an MRI discussion. Can I ask what the MRI is?
The initial MRI was level 2, PSA over 10, and the exosome 27.
I think you should do the biopsy. I mean, there's an 80% it will come back negative, but 20% chance there will be something.
Okay. And
well, I'm referring to other people also in the room.
Cutoff is 11 for an ExoDX. Full cutoff is 11 for low risk.
Yeah, so it's a 20 plus. That's what I'm saying, it's a 20 plus. So.
Would a second MRI make a difference?
How long ago was your first MRI?
The initial MRI was 6 months ago, and I just did a repeat MRI, and I'll get results tomorrow.
How did you manage to do that? Within 6 months. Anyway, I think just take it out. So, in this situation, I sometimes change the game. Get a 4K.
Okay.
Yeah. Because urinary marker is elevated, PSA is elevated, let's see what the 4K shows. And 4K is a blood test. Yeah.
In terms of post-operative patient, how do you expect the Decipher database to guide your therapy? And let's say, I'm here, Dr. Tewari. To the left.
Hi.
How do you expect the Decipher testing to guide your therapy with, let's say, Gleason 7?
If Decipher is high and margins are negative, lymph nodes were negative, there was no T3 disease, PSA is undetectable, I will just keep doing your PSA every 3 months for a long time. Normally I do PSAs every 3 months for first year, 6 months second year, and yearly from that point on. In your case, I will just do a PSA every 3 months for a long time. Ultra-sensitive PSA, that's what the keyword is. I don't think anyone will give you radiation, I don't think anyone will give you chemotherapy, but if your PSA starts creeping up, I will be a little bit, that mindset. So don't do anything, just do the PSAs, don't change the PSA location, don't do it 10 different places, just stay with one lab, ultra-sensitive PSA, that kind of thing.
So in this case, the Decipher testing is guiding your further treatment in terms of...
Not further treatment, further follow-up protocol, meaning there is a more likelihood of this cancer coming back, but this is based on the tissue which is already out.
Another way of doing this is to see whether you can use the Decipher to avoid radiation and hormones. Now, radiation the body can tolerate well, but long-term hormonal therapy, most patients will feel miserable, about 30 to 40%. So if you have someone, if your radical prostatectomy specimen showed Gleason 8 disease, most doctors would recommend radiation therapy as soon as the PSA starts creeping up, or even before. But about 10% of these men will have a low Decipher score, even with the Gleason 8 cancer. And if you have organ-confined disease and a low Decipher score, then you can watch and you don't need immediate radiation. You can avoid the side effects, not of the radiation itself, but of the hormones that go with the radiation.
What's the next question? Please, sorry.
Say anything about advances?
Sorry, I'll get to it. He started saying it, just a second.
Nerve-sparing techniques in surgery.
Mm-hmm.
Can you say something? You mentioned in the program that there would be some discussion of that.
Did you guys watch a video outside in 3D?
Yeah. Yes.
So, this is talking about the different grades of nerve-sparing discussion. Nerves around the prostate, they travel in a very close confine, and there are different compartments around the prostate. And based on what's the likelihood of cancer touching the capsule, we make adjustments to how to save the nerves. So this is what we call an athermal nerve sparing technique, in which we will do either grade 1, grade 2, grade 3 nerve sparing, and that helps in recovery of the sexual function. I mean, this is another trick which we have started doing it, which we call an hydrodissection. And in spite of doing it, it doesn't work in everyone. But these are the ways we are trying to So nerves are hiding in the tissue. So I have been doing some new tricks. And if someone is going to faint on me, tell me first. I didn't. I do about 3 every day, and this is basically understanding the anatomy, changing your course, pre-planning, and being very delicately doing this thing.
3 a day?
Yeah.
I want to be the first.
The skinniest guy is the first.
That's good. What is the scale of those teeth?
This big.
Okay, thank you.
This big. And it's magnified very high. But you can see, and you will be able to see the nerves. This is something new which I have started doing in the last couple of years. And
so there's no cautery here.
I mean, close to the nerves we avoid it. That's so.
And right now you're still clipping away for the nerve?
You'll see the nerves at the end of it.
Okay.
But it's a flimsy, that's really, it's your less than your eyelids. While we are watching it, I can answer the question which we had. You focus on this.
Going back to hormonal therapy, what are the side effects, and is it something that you need to take the rest of your life?
Fatigue, lack of energy, metabolic syndrome, weight gain, sometimes breast enlargement, hot flashes, and sometimes memory loss. These are the main side effects within hormonal therapy. Am I missing something?
Sexual drive.
Sexual drive. That's the sexual team, that's the reason they only bringing it up. So I will have a question for both of you. What's our protocol for the rehab afterwards?
Sure. So a lot of patients.
First introduce yourself. I have not done a good job.
My name is Leon Tellis. I'm a relatively new faculty at Mount Sinai. I specialize in mental health and male sexual dysfunction. And post-prostatectomy care is a passion of mine as well. And we'll often talk to patients prior to surgery to counsel them on what they can expect after surgery or radiation. Usually the best predictor of what erectile function will be after surgery is what your erectile function was prior to surgery or prior to any kind of treatment. And we'll often start patients on a course of PDE5 inhibitors or your Viagra's and Cialises that everybody's probably heard of immediately after surgery. Some patients just will recover good function with that. Some patients will progress to other treatments such as injections if medications are not enough.
So, when do you think, who do you encourage for the injections and gel?
I didn't know what you said.
Which patients do you encourage injections and gel?
Well, a lot of times it's a personal choice, you know, because a lot of men are very scared to even start with the injections. So they like to try the gel first. The gel is an intraurethral gel. It goes up your urethra. So there's no needles involved or anything like that, and it works very well for a lot of patients. But unfortunately, everyone absorbs medication differently, so they may have to do the injection. You know, so we start off with the pills first. Then, if you're not recovering, then we'll try to go with either the gel or the injection.
Any other point you want to make? You may want to talk about the penile implant discussion.
Yeah.
I mean, because
So-
there are some patients who will need it.
Yeah, there's a certain group of patients that may either not respond well to injections or to the gels, or they may just not like injecting themselves. And those patients can sometimes elect to get a penile prosthesis, which there's a couple of different kinds. The most common one is what we call a 3-piece inflatable penile prosthesis that is a mechanical device that gets implanted. It's about an hour-and-a-half surgery, and the way it works is with a pump that's located in the scrotum. When you want an erection, you inflate it. It works every time. Sensation remains the same. Orgasm remains the same. The pump is essentially just replacing the actual mechanical function of the erection. And patients are generally very satisfied with those devices.
So, go ahead.
A question regarding the wave therapy.
Wave therapy, yeah.
Could you explain that in simple English?
Shockwave.
And procedurally what that is?
Can I say it before they say it? It only works in 20% of the patients. It's very expensive.
Yeah.
But go ahead.
I would like to echo what Dr. Tewari said. There are some patients that would like to try it because it is fairly minimally invasive. The most invasive portion of it, honestly, is on your pocketbook. But it works with sound waves, shock waves, in order to attempt to generate new blood vessel growth within the portion of the penis that's responsible for erections. And the thought is, with that new blood vessel growth, that you can improve blood flow and increase erections. But like Dr. Tewari said, there is about only roughly 20% chance that that'll work. I will also say that patients who have not had an erection in years, chances are that probably won't work.
Yeah, one other thing with it is if somebody's getting a decent response with the pills, but not quite there, it may help a little there as well. You know, if you're getting close to where you want with like Viagra, Cialis, it may push you up to the edge where it's much more a rigid erection.
So what if you have an erection every day for 365 days, and then you're put on a medicine prior to surgery for an erection? What do you think the outcome will be with your sparing technique?
Depends what kind of a cancer you have. What's your MRI finding? What's your Gleason score? If it is not, and so anywhere between 70 to 85% chance it will come back, and it usually takes longer than what you expect it to be. But all depends on whether it is within the prostate or outside. That's the key. So, I mean, and we do intraoperative pathology at that time too. meaning we take the whole specimen, we take pathologist calls that you need to, because it's a microscopic. But it's much better, but it is not applicable to everyone. Patients who have a high-grade cancer, patients who have a high-volume cancer, patients who have a cancer on an MRI looking at abutting or extracapsular extension, that's where you have to kind of settle down when it's full. We can save it most of the time, but there are options, and we have to have that discussion about the options beforehand. Any other question? Who is the last question? No, last two questions, because I can see two. Go ahead.
Okay, I can deal without getting an erection, but I cannot deal with incontinence. Can we talk about, I'm getting urologic prostatectomy in a couple of weeks. Can we talk about the recuperation on the incontinence and what I should expect? Briefly.
So there are two different ways of doing urology, three different ways. I mean, it's conventional way. There is one known as ridge sparing, and the third is known as an anterior hood procedure. Ridge sparing and hood procedures tend to have a better continence results. But ridge sparing sometimes constrains your surgery, so people have a little bit more positive margins, meaning the cancer left behind a little bit more. Bottom line is, at the end of a year, 95% chance you'll be fine. In my hands, in 3 months, what's the number, Vinayak?
It's 91%.
And now, it's about 6 months, it's a 91%. At 3 months, it's about 70% patients. Yeah, so that's about, and then how we have a very crude way of measuring continence that you don't need a pad. But even if you're not needing a pad, and if you go to Jerry Seinfeld's show, you may need. So there's a slight bit of an adjustment, but most people, there is a good chance, 9 in 10, I can say that this will not be an issue. And if it is, we have Dr. Grafstein who knows how to fix it very easily. Hopefully. Okay. So there was a question. Last question is close to the.
This is going back to the PSA question. So this morning I went to see a pathologist. I thought I had hemorrhoids and it was negative. And he was like, well, since I'm there, let me check your prostate. And right before I came here, I took a blood test across the street, on the truck. Is that going to impact the results?
Yeah, it may be higher than your normal because you had some rectal procedure at this point.
So I have to do it again. Okay.
That's okay. If it is normal, then you're okay.
No, I know, but I
meaning if it is normal, then
I mean, I didn't know that before
normal, then it's a good thing. But did you get the result today, just now?
No, I gotta check my email, I guess.
Yeah.
Okay. Thank you.
Please, go ahead.
You said black people should take the test anywhere between the 40 and 45. That's what I heard one of the slides. Is there a reason why it's so high among black people?
So on an average, men with 55 years of age, they should get a PSA testing done, and 55 to 72, 70 is the number. But for black men, the age is about 40. Reason being, they have twice the mortality of the prostate cancer, and they have a pretty high incidence of prostate cancer. It is multifactorial. By multifactorial, I mean there are certain metabolic pathways which are involved. There are certain inflammatory pathways which are involved, but one of the most important reasons they have a little bit higher mortality is because they don't get the testing done. And that's partly because we haven't done a good job in eliciting our trust amongst them. So we have to, as a doctor, do a better job in convincing that it's the right thing to do. Second thing is, if there is a social impediment, if there is a cultural impediment, if there is a financial impediment, the prevention comes later in their life. Third part is, there is a stigma about the exam and the rectal exam and all those things can be a discussion point. I don't want to drag it into it, but at least getting a PSA is a good idea. One thing I do know, that if we find it at the same time and at the same stage, outcomes can be pretty comparable. So we can change the even the playing field by finding the cancer early, and that's the reason this entire initiative which I have tried to put together is in van goes to every place and get the PSA. And so one thing you can help me with it, men don't talk about PSA, men don't talk about the prostate cancer, we talk about the cards, we talk about the game, so but talk about it. I'm trying to reach out to the barbers, I'm trying to reach out to ladies, and that's the reason. Just get a PSA done, and after that, many people don't need anything, but those 5, that will be a lifesaver for them. So, please.
I just wanted to share my own experience on the issue of African Americans and the high incidence. I have a brother who right now has prostate cancer. He's been battling it for about 6 years now, and now he has metastatic. And so he's now fighting through that. But he is my oldest brother, then I have it, and then my brother under me has it. So somehow I think there's 2 things I think. One is cultural, where men just don't talk about it in our culture. And I found out when I found out I had it, then my brother told me. He never shared that information in the family. So what I'm doing now is I'm sensitizing all the males in my family. I'm sensitizing them to the issue. And at 40, I'm telling them at 40, they need to make sure that they start getting their PSAs checked. It wasn't until I started talking about it that my other brothers then started to say, oh yeah, well, that happened to me. Well, you should have said that before, but I haven't because I'm in New York, and I'm more sensitive. In fact, my own employment, I'm involved in the medical field anyway. So I'm very sensitive to when things start happening to me physically. I have a very good primary physician that I can talk to. And that's how my journey started. But in the African American community, we just simply don't, as men, we don't talk about it enough. We're peeing wrong, or something something strange is happening that might indicate an enlarged prostate. We just simply deal with it privately, and we don't talk among ourselves about issues. And unless you speak about them, then no one knows. And everybody can have that same problem, or many people can have that same problem in the same family, and no one knows about it.
And it's totally winnable battle if we find it in time. And that's why you can help us in magnifying. Just go and tap on the shoulder to some other person that, hey, you know what, did you get a PSA?
And even at family reunions, places where, I know my family gather, I speak openly about it, so that the young men know that it's really important for them to get tested at a certain age.
Thank you.
Thank you.
You are a brave person. Please.
I just wanted to just express that it is important for African American men to get tested because of the high rate. But everything that we are afraid of, which is the rectal exam that they had to hang up about, and the coming into the doctor and getting it and being scared. Was I scared? I was frightened. But getting it early is the key. Getting the word out is the key, because I had 2 other friends get tested. They were much further along than I was. Dr. Tewari has an amazing team of specialists that dealt with sexual function, urinary incontinence. I heard one guy said, oh, me being incontinent is important, but me being alive is more important. And if I have to wear a pad, then I'm gonna wear that pad. But he has someone in every area to deal with every problem that may occur after surgery. The importance is to sustaining your life. So at looking at it from that perspective, whether I can have sex again, you can have sex again. Is it a slow process? It is a process, but it's different. But life is different after cancer. So the thing is to get the word out, especially amongst African American men, to get them into the doctor, and to also get the word out about men discussing prostate cancer as a whole, to get them to get their PSA checked. Most men don't know what their PSA. I'm like him, work in the medical field, know what my PSA was. And as soon as they told me it was a 3.7, I knew I was in trouble. So we want to get people in, get the word out, and get men of color especially tested so we can get it early. So once you get it early, you'll be able to deal with the battle.
I couldn't have had a better closure than this statement. So thank you again for being here. Let's reconvene again. Give me suggestions, my email, cell phone, and great to have you here. Hopefully we'll win this battle. If anything we can improve, change, I'm totally ready for that. Help me out. Thanks.